So in this short module, we are going to discuss about the clinical features of inflammatory bowel diseases. So in the previous module, we had seen that there are certain overlapping features in the etiopathogenesis of Crohn's disease and inflammatory bowel disease. But coming to the clinical features, we will see that both Crohn's disease and ulcerative colitis, they've got intestinal manifestations and extra-intestinal manifestations. The intestinal manifestation, the presentation is slightly different for Crohn's disease and ulcerative colitis, whereas the extra-intestinal manifestations, again, there is a considerable degree of overlap with certain extra-intestinal manifestations that can occur in both Crohn's disease as well as ulcerative colitis. But at the outset, I want to tell you that overall, if you discuss the clinical features of IBD, it depends on which part of the bowel is involved and how severe is the involvement. So based on that, the clinical features can vary. Okay. So in the initial part of the discussion, we'll discuss the clinical features of Crohn's disease, that is the intestinal manifestations. Then we'll move on to the intestinal manifestations of ulcerative colitis, and then we'll discuss the extra-intestinal manifestations. Okay. So to begin with, we'll see the clinical features of Crohn's disease. As I already told you, Crohn's disease can have variable symptoms depending on which part of the bowel is getting involved and how severe is the involvement. It's a chronic disease with active relapses. Okay, in between you can have certain remissions as well. So active disease interrupted by asymptomatic periods, which can be weeks or months, and you can have these relapses triggered by certain factors. So what are the reactivation triggers? You can have physical and emotional stress. Okay, physical and emotional stress, cigarette smoking, these are all triggers for the relapses. Okay, right. Now moving on to the clinical features based on the region of the bowel that is involved. We'll first see what happens in case of ileocolitis in case of Crohn's disease. So when there is an inflammation involving the ileum and colon, the patient commonly presents with right lower quadrant pain, diarrhea, and also weight loss. Okay, and sometimes the clinical presentation can very much mimic an acute appendicitis. Okay, acute appendicitis, wherein the patient can have fever, a palpable mass, and leukocytosis. So similar to acute appendicitis, you can have a presentation. But remember that patients with ileocolitis, especially when you can have stricture formation, this can lead on to bowel obstruction. Okay, so the disease, as I told you, can have all this lower quadrant pain and diarrhea, but sometimes can lead on to bowel obstruction as well, especially when you have got a stricture formation. Okay, right. You can also have fistula formation, and the fistula formation can be between the bowel to bowel, which is called enteroenteric fistula. Okay, you can call it enteroenteric fistula. You can have between bowel and skin, which is enterocutaneous, and between bowel to bladder, which is enterovesical. Okay, enterovesical fistula. Okay, so this can also have manifestation. For example, in case of enterovesical fistula, you can have the patient having frequent urinary tract infections. The patient can have dysuria. Okay, but I want to tell you something. Though you can have diarrhea as a prominent manifestation in Crohn's disease, the rectal bleeding is rare. Okay, so you can have, but relatively rectal bleeding is rare compared to ulcerative colitis. Okay, compared to ulcerative colitis, rectal bleeding is rare. Okay, right. Then coming to jejunoileitis, suppose there is a inflammation involving the jejunum and the ileum. In that case, again, here you have got involvement of the absorptive surface area. So patient can have features of malabsorption and steatorrhea. Very important. So patient can have nutrient deficiencies, patient can have steatorrhea. So these can happen in case of the jejunal plus ileal involvement. And patients can have diarrhea. And what is the reason why the patients develop diarrhea? It can be due to bacterial overgrowth, bile acid malabsorption, because ileum is important for the enterohepatic circulation, for reabsorbing the bile acid. But if there is an ileal involvement, you can have bile acid malabsorption leading on to a bile acid diarrhea as well. Intestinal inflammation is also one factor that can lead on to diarrhea. And also diarrhea may be a consequence of the enteroenteric fistula as well. Okay, so this is what happens when there is a jejunoileitis. Now what happens in Crohn's disease when you have got a colitis? So colitis can present with low-grade fever, malaise, diarrhea, and a crampy abdominal pain. Sometimes hematochezia, and I have already told you, gross bleeding is uncommon. Okay, you may get a hematochezia, some blood in stools, but gross bleeding is uncommon. And when you have got a colonic stricture, again, you can have bowel obstruction. And fistula is another problem. You can have fistula between the colon and the stomach, wherein you can have a feculent vomiting, and fistula between the colon and the small bowel, wherein this channel can result in malabsorption. Direct passage from the small bowel to colon can result in malabsorption as well. Okay. Now, perianal disease is common again with Crohn's disease, very rare in case of ulcerative colitis. You can have skin lesions like skin tags, anal canal lesions like fissures, ulcers or stenosis, perianal fistulas as well as perirectal abscesses. So these are the manifestations when you have got a perianal involvement in Crohn's disease. Okay. You can have upper GI involvement, though it is very rare. So you can have a gastroduodenal disease. So in that case, the patient has nausea, vomiting, and epigastric pain. And advanced cases of upper GI involvement can have gastric outlet obstruction. Okay, right. So these are the clinical features of a Crohn's disease. And rarely, Crohn's disease can progress to malignancy as well. So there is a mild increased risk of CA colon, and that is in case of colonic involvement. Okay, only if there is a colonic involvement, not in case of any sort of gastroduodenal disease, but when there is a colonic involvement, there is a mild increased risk of CA colon. Okay, now moving on to the clinical features of ulcerative colitis. Okay, so ulcerative colitis, the clinical presentation is slightly different, especially with regards to the intestinal manifestations. And I want all of you to listen to this carefully, because in clinical scenarios, you will have to diagnose, is this ulcerative colitis? Is this Crohn's disease? So for that, you have got to know about the clinical features. So clinical features of ulcerative colitis, the patients can have diarrhea, rectal bleeding, very, very important. Rectal bleeding is an important feature of ulcerative colitis. And you can have that frequent urge to pass stools, even when you do not have stools. So that is called tenesmus. Passage of mucus can be there, sometimes blood alone, sometimes blood with mucus, sometimes mucus alone. Then crampy abdominal pain may be there, and constipation. Remember, usually what happens is diarrhea. But when there is a distal colitis, that is when you have got a proctitis or a proctosigmoiditis, so in that case, the proximal motility might be reduced. In that case, you can have a constipation. Otherwise, what do you expect? Diarrhea. Okay. And some patients, especially severe form of ulcerative colitis, can have certain systemic features like fever, fatigue, and weight loss. So all these symptoms can be there, but remember, the severity of symptoms will correlate with the extent of disease in case of ulcerative colitis. And as discussed with Crohn's disease, this is a chronic disease with relapses and remissions. Here also you can have triggers, and the triggers may be a stress, gastroenteritis, antibiotics, NSAIDs. Complications of the condition, well, ulcerative colitis can lead on to massive hemorrhage at times. You can have toxic megacolon wherein the wall becomes thinned out, and if you have got an increase in the diameter of the transverse colon and the right side of the colon, okay, the left colon is usually the diseased part. So when the diameter of the transverse colon or the right colon exceeds more than 6 centimeter, it is called toxic megacolon. And toxic megacolon, it is carrying a risk of perforation as well. There is a risk of perforation associated with toxic megacolon. And there is an increased risk of colon cancer. Okay, so the risk of colon cancer is more with ulcerative colitis compared to Crohn's disease. Okay, so these are the complications. Okay, now this important table in Harrison is also worth knowing, because you might get clinical scenarios of ulcerative colitis, and to decide on the management, you will have to categorize it as mild, moderate, or severe. So this will actually help you in such a categorization. So what is this known as? This is a Montreal Classification, and this takes into account the extent of ulcerative colitis and severity of ulcerative colitis. Okay, so we are discussing the extent as well as the severity. So extent E, based on that you have got E1, E2, E3. So what is E1? E1 is ulcerative proctitis, where the involvement is limited to the rectum. Then the left-sided ulcerative colitis, also known as the distal ulcerative colitis, where the involvement is limited to the colorectum distal to the splenic flexure. Then you have got the extensive ulcerative colitis or pancolitis. I already told you around 20% can have a pancolitis, where the involvement extends proximal to the splenic flexure. So this is E1, E2, E3, important. And based on the severity, yes, severity, you have got a classification into S0, S1, S2, S3. S0 is the phase of clinical remission, wherein the patient has absence of any sort of symptoms. Patient is in remission. Then mild disease activity, wherein the patient has less than or equal to 4 stools per day. This is important, with or without blood. Okay, so less than or equal to 4 stools per day with or without blood, with absence of any systemic features like fever, tachycardia, and normal inflammatory markers. So no signs of any systemic features. In that case, you will categorize it as a mild disease. Moderate disease, more than or equal to 4 stools per day, but has minimal signs of systemic toxicity. Whereas the last one is the problematic one, mainly the severe disease activity, wherein you get more than or equal to 6 bloody stools per day with pulse rate more than or equal to 90. Okay, so slightly on the upper side, temperature more than or equal to 37.5 degrees Celsius, hemoglobin less than 10.5 gram per deciliter, and ESR again on the higher side, more than or equal to 30. So based on that, you can categorize from S0 to S3. Okay, so that is also clear, right? So we have discussed about the intestinal manifestations of Crohn's and ulcerative colitis, and you see how different presentations they are in spite of the overlapping etiopathogenesis. Okay, right. Now coming to the extraintestinal manifestation. See, I want you to know that roughly 1/3 of patients with inflammatory bowel disease can have extraintestinal manifestations, and multiple organ systems can be involved, but most frequently it involves the joints, skin and eyes. Can involve other organs like liver, pancreas as well. Now, if you look, most of the extraintestinal manifestations can be present in both Crohn's disease and ulcerative colitis, but you will have certain extraintestinal manifestations which are slightly more common in Crohn's disease and ulcerative colitis, and certain extraintestinal manifestations more common in ulcerative colitis than Crohn's disease. Okay. Now, let's see them one by one. And before that, I just want to tell you one more thing that, see, when you take into account all these extraintestinal manifestations, some of the extraintestinal manifestations are related to the bowel activity. So, which means they are likely to occur in the active phase or the relapse phase of an inflammatory bowel disease. Whereas some extraintestinal manifestations are unrelated to the severity of bowel activity. So what is the importance? The extraintestinal manifestations which are related to the bowel activity, once the IBD is controlled, the extraintestinal manifestation also will be under control. But there will be certain extraintestinal manifestations that can persist in spite of the disease being under control. Okay, in spite of the IBD being in remission. Okay, right. So let us move on to discuss the extraintestinal manifestations. First of all, joint manifestations. Very common extraintestinal manifestations. You can have different sorts of joint involvement. One is a peripheral arthritis, and if there is a peripheral arthritis, it's usually asymmetric, polyarticular and migratory. You can have ankylosing spondylitis. You can have sacroiliitis without an accompanying ankylosing spondylitis as well. So I want you to know this peripheral arthritis. Okay, this peripheral arthritis, this is related to bowel activity. Okay, this is related to bowel activity. So active phase or the relapse phase, you are likely to get the peripheral arthritis. Whereas ankylosing spondylitis and sacroiliitis, they are unrelated to bowel activity. Okay, unrelated to bowel activity. So even when the disease is not very active, you can get ankylosing spondylitis and sacroiliitis. Okay, right. And some patients with ankylosing spondylitis, they can have HLA-B27 positive as well. Okay, right. Right. So this is about the joint manifestations. Coming to the dermatological manifestations, there are a lot of dermatological manifestations. Okay, I've just listed the most important ones. Erythema nodosum, pyoderma gangrenosum, psoriasis. But what is the important MCQ point? The erythema nodosum is the one that is again related to bowel activity. Okay, related to bowel activity. Whereas your pyoderma gangrenosum and psoriasis, they are unrelated to bowel activity. Unrelated to bowel activity. Okay, right. Important. Now coming to the ocular manifestations. Ocular manifestations, episcleritis, anterouveitis, and again episcleritis. This is again related to bowel activity, related to the severity of bowel activity. Enterovesical is not related to the severity of bowel activity. Okay, this is important. Okay, so these are potential MCQs. They might ask which of the following manifestation is related to bowel activity. Okay, so this is again important, right? Coming to hepatobiliary manifestations, this can be in the form of fatty liver, cholelithiasis, primary sclerosing cholangitis, and cholangiocarcinoma. These are the hepatobiliary manifestations. And remember, the primary sclerosing cholangitis and cholangiocarcinoma, this is a previous MCQ, is more common with ulcerative colitis than Crohn's disease. Can be seen in both, but more common with ulcerative colitis than Crohn's disease. Urologic manifestations, nephrolithiasis. So usually it is a calcium oxalate calculi that can be associated. Okay. Then coming to metabolic bone disorders, you can have osteoporosis as well as osteonecrosis. And osteoporosis is there. Osteonecrosis is actually more common with patients who are having chronic steroid use. You know that in the management of the inflammatory bowel disease, we'll be using steroids in certain patients, especially in those patients, they are at a higher risk of developing osteonecrosis. What are the other extraintestinal manifestations? Remember, very important, patients with inflammatory bowel disease are at a high risk of developing thromboembolic disorders. This is an important previous year question. Okay, you can have risk of systemic amyloidosis, pancreatitis, and cardiopulmonary disorders like endocarditis, myocarditis. You can have pericarditis, maybe even with an adjacent pleural involvement as well, pleuropericarditis, and then you can have interstitial lung disease as well. Okay, so these are the cardiopulmonary diseases that can be associated with the inflammatory bowel disease. Okay, so basically in this short module, we just had a quick look at the clinical features of Crohn's disease, ulcerative colitis, the associated complications, and the extraintestinal manifestations as well. Okay, thank you.